You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for September 1st, 2023. This is the first of many ESC Wrap-up podcasts. It was a big meeting and it'll take a number of podcasts to get all of the important trials from that meeting. Today, the topics that I'll include are obesity, heart failure, both with preserved and reduced ejection fraction, atrial fibrillation, frailty, evidence translation, and of course, catheter ablation. Wow, what a meeting in Amsterdam. I just love that city. I only got in a car twice, to and from the airport. Otherwise, I used a rental bike. Even when I wore my suit, I used a bike. Imagine riding a bike with an Italian suit. Perhaps my favorite was riding at night home from dinner. I also want to thank Irish cardiologist Dr. Daniel O'Hare for reminding me about the Park Run 5K on Saturday. He and Soren Didrikson shredded me, but I loved it. Now, on the meeting itself, either this was a very small Congress hall or the attendance was amazing because, gosh, there were a lot of people there. And I think medical meetings might be back. ESC did a great job of attracting a lot of really important studies. And again, it's going to take a number of podcasts to cover them all. Finally, to all of those who came up to me and mentioned the podcast, I say thank you times 1,000. It means a lot to me. It motivates me to keep trying to get better at this. A super special thanks to Dr. Robert Thielman from the Netherlands, and you know why. I'm going to start my review with the most important study presented at ESC. No, it wasn't semaglutide or AFib ablation or anything about PCI. This study should send shockwaves through you every time you move to apply evidence from trials to a patient, especially if you think you are following guidelines or quality measures. This study dealt with oral anticoagulation for stroke prevention in patients with atrial fibrillation. It was called the FRAIL-AF Study. It was set in the Netherlands in multiple general practice offices. Associate Professor Dr. John Mandrola and his PhD candidate Dr. Linda Joosten designed a study to test the safety of switching patients from vitamin K antagonist to direct-acting oral anticoagulants, or DOACs. Now, a sidebar is that in the Netherlands, the vitamin K antagonists are different than ours. Ours is warfarin, and the ones that they use in the Netherlands are different, and they're very difficult to pronounce, so I'm not even going to try. But they all work in the same way to antagonize vitamin K and elevate the INR. Now, this switch sounds like a no-brainer, right? I mean, Christian Roos meta-analysis in The Lancet of the 4 seminal warfarin versus DOAC trials found that DOACs are better at stroke prevention and associated with numerically less major bleeding. But here is why the FRAIL-AF study tops my list as the most important study. Because these authors studied the switch in elderly patients who had frailty. Oh, I've got a column coming out probably next week on the FRAIL-AF study, so I won't give it all away. But the short story is that FRAIL-AF investigators designed the study out of a bit of frustration that there is really no evidence on the issue of using DOACs in these older patients with frailty because so few of these types of patients were included in the trials. And since, by definition, frailty increases your vulnerability to adverse effects, and also frailty comes with many competing causes of morbidity, we can't be sure that DOACs would prove superior in these sorts of patients. So FRAIL-AF randomized like patients that were 83 years old, They had serious frailty measures, basically homebound. They were managed on vitamin K antagonist, and the choices were staying on the VKA or switching to a DOAC. And the question was safety. Major bleeding was the endpoint. They powered the study to show that DOACs were superior to vitamin K antagonists for major bleeding. But boom, that is not what they found, not at all. Now, I'm not going to go and totally give my column away. I want you to read it and comment on it when it comes out next week. But the teaser is that after the first interim analysis, the trial was halted for futility and harm in the switch to the DOAC group. Yes, bleeding was higher in the DOAC group. Imagine designing a trial for superiority and finding not only superiority, but the active arm was worse. I think this is a huge finding. I'll make many arguments, mainly 3 arguments in my column, that if you use evidence to treat patients, FRAIL-AF is the most important study from this meeting. Taking average effect size from trials and applying them to the patient in front of you will become the greatest challenge facing the doctors of the future. And the surprising findings from FRAIL should infuse us all with big doses of humility when we use evidence. I hope this study finds its way to guideline writers and anyone silly enough to think quality measures are a good thing. All right, next topic is the STEP-HFpEF trial. Now, FRAIL-AF should have led the meeting, but it did not. A trial called STEP-HFpEF led it off. STEP-HFpEF made the New England Journal of Medicine, and it earned a ton of press coverage and praise. STEP-HFpEF studied the use of the glucagon-like peptide-1 agonist semaglutide in patients with HFpEF. Now, HFpEF is a serious condition. It causes a lot of hospitalization. It leads to cardiovascular death. We certainly need better therapies for patients with heart failure and preserved ejection fraction. So you probably figured the lead hotline trial at the biggest heart meeting in the world would enroll many thousands of patients and address heart failure hospitalizations or CV death. Well, you would be wrong. STEP-HFpEF is a classic marketing masquerading as science type study. This was an industry-funded study and enrolled only 500 or so patients who had obesity and HFpEF, and it measured, sit down for this, weight loss and quality of life, measured on the KCCQ questionnaire. Yes, of course, the first of the dual primary endpoints, weight loss, was positive. I mean, patients lost weight. That's what they do on semaglutide. We already know that. We knew that from multiple studies. Now, for the second primary endpoint, quality of life, semaglutide treatment was also associated with better scores. But again, which patient who is obese and then loses a bunch of weight does not report feeling better? Of course you feel better when you lose weight. Now, they also looked at 6-minute walk tests and a host of biomarkers, and these all were better with weight loss. Of course they were. Now, if this is the metric for GLP-1 agonist, you could literally use them in any condition in which patients are obese. I don't offer this criticism because I'm against this drug class. The ability to induce weight loss could lead to a massive gain in health, because right now I feel like obesity is one of the gravest threats to health in the Western world. We see obese patients every day. Yet, if you're looking to show that your drug specifically helps patients with a condition as serious as HFpEF, design a proper study that looks at clinical outcomes, such as heart failure hospitalizations or CV death. Now, I read somewhere that the valuation of Novo Nordisk, the maker of semaglutide, is close to or surpassed the entire GDP of Denmark, so there's certainly plenty of money to do such a study. The title of my column that's out on the heart.org Medscape Cardiology is Semaglutide Cleared a Low Bar. All right, next topic, atrial fibrillation, the NOAH-AFNET 6 trial. Not every day, but most days, I get a notification from our pacemaker center that a patient who has oodles of stroke risk factors has had some atrial high rate episodes on their device. AHRE, or atrial high rate episodes, are really just atrial fibrillation, but short in duration. Maybe minutes, maybe hours, but not long enough to visit a doctor to get a 12-lead ECG. Should we start oral anticoagulation in these patients? That is the question that comes up often. But before ESC, no one had any answers. And of course, smartwatches have made this problem worse because they too pick up short duration AFib, albeit with a lot lower specificity than, say, a pacemaker. At ESC, we heard the details of the NOAH-AFNET 6 trial, or NOAH for short. It answered some questions. Now, how many questions that it answers depends on your point of view. So let's do some details. NOAH had about 2,500 plus patients with AFib greater than 6 minutes on a cardiac device, pacer or ICD mostly, mean age 78 years, randomized to either a DOAC, edoxaban, or placebo. Now, about half the placebo group were on aspirin for aspirin indications, such as coronary disease. Their primary efficacy endpoint was a composite of stroke, embolism, or CV death. Primary safety endpoint was death or major bleeding. Now, we knew before ESC from a press release that NOAH was stopped for futility, but at ESC, we also learned that it was stopped for harm. The safety outcome, death or bleeding, occurred in 5.9% of those in the edoxaban group versus 4.5% in the placebo group. That's a statistically significant 1.3% absolute risk increase, or relative 31% higher risk. The higher risk was driven by 28 more major bleeding events in the edoxaban arm. As for efficacy, primary outcome, stroke, systemic embolism, or CV death occurred in 3.2 versus 4.0% in the edoxaban versus placebo arm, respectively. The hazard ratio, get this, was 0.81, but the confidence intervals went from 0.6 to 1.08, and thus it is not considered statistically significant. Now, here are some of the take-homes that I wrote about in my column on the heart.org Medscape Cardiology. First point was that this was strong evidence against treating short-duration AFib with DOACs. Consider that these were high-risk older patients, mean CHA2DS2-VASc score 4, and bleeding rates were substantially higher than the stroke reduction. Second point, there's another trial coming out soon called Artesia. This is studying similar patients and testing apixaban versus aspirin. Artesia will recruit more patients, follow them for longer, and it has not been stopped for futility. The problem, of course, is that having aspirin in the control arm, which I think is a bad idea, is going to decrease the difference, the delta in bleeding. Nonetheless, rumors have Artesia reporting at the American Heart Association meeting in 2 months, so we should hold out definitive conclusions until we see that data. Third point, NOAH clearly advances our knowledge about the prognosis of AFib and how it differs depending on the diagnosis. In the past, AFib had to last long enough or create enough symptoms to trigger a clinician to order a standard ECG, right? Continuous monitoring now requires neither symptoms nor long-duration episodes of AFib. So NOAH, I think, gets close to proving that short-duration AFib is a lower risk condition than a 12-lead ECG-defined AFib. It's possible, and I'm wondering whether short-duration AFib might simply be a condition of aging like gray hair and wrinkles. Fourth point, NOAH is like the FRAIL-AF study in that it demonstrates the power of randomized trials. I constantly hear how trials are too expensive to run. They're too pricey. But now consider the cost of inappropriately treating millions of people with short-duration AFib. In the end, I think many of these trials pay for themselves and then some. Final point, NOAH really decreases my enthusiasm for screening for AFib. Screening programs often pick up short-duration AFib, which is fine, but picking up AFib is not enough, right? In screening, you have to show that the treatment of picking up this early disease leads to benefit. NOAH suggests that it does not. Now, one caveat is that an astute reader has already sent me a message that there may be a sweet spot of picking up AFib. That reader said that one of the reasons NOAH may have been null was that older patients have too many competing comorbidities, for instance, higher risk of bleeding. Screening and picking up AFib in the younger patients may still be worthy, as younger patients have fewer competing causes of stroke. I don't agree with that because I think younger patients are going to have too low a stroke risk, but the commenter makes a good point about always thinking about competing risks of the primary outcome. All right, next trial also in the AFib space is called the ADVENT trial. One of the most exciting things in the AFib world is a new technology to perform AFib ablation, which is basically still electrical isolation of the pulmonary veins. The new technology is called PFA, or pulsed field ablation. The idea is to send electricity, think shocks, through a catheter, and it creates pores in the myocyte membrane. We call this electroporation. Now, the neat thing about PFA is that it's supposed to affect only cardiac tissue, which is important because the most feared complication of AFib ablation is thermal damage to the esophagus, which can be deadly. Phrenic nerve injury, too, is a big issue, especially with cryoballoon ablation. At ESC, Dr. Vivek Reddy presented results of the ADVENT trial, which was essentially an FDA regulatory type trial. PFA is already approved in Europe and widely used in some countries there. ADVENT had 300 patients with paroxysmal AFib. It was done in U.S. centers, and it was PFA versus thermal ablation. Now, thermal could be RF or cryoballoon. The primary endpoint was a composite of freedom from the initial procedure failure, any AFib or AT, use of antiarrhythmic drugs, cardioversion, or repeat ablation. Basically anything bad that happens with recurrent arrhythmias after the procedure. And the results of ADVENT were extremely similar. Kaplan-Meier curves were pretty much superimposed. Success rates were in the 71 to 73% range. Now, procedure times were shorter in the PFA arm. Safety was also similar, not better, similar, although the only two tamponade cases were in the PFA arm, and one of these patients died from the procedural complication. There were no atrial-esophageal fistulas in either group, which of course is what you'd expect. Since the incidence of this complication is super low, there's very little chance that a trial of 300 patients would pick up an atrial-esophageal fistula if the incidence is 1 in thousands. Phrenic nerve injury, however, did occur in the PFA arm. I thought it was cardioselective. Now, all 4 cases of phrenic nerve injury in the PFA group resolved, but it did occur. I also wrote a column about PFA, and I have to say I am underwhelmed. Now, proponents of PFA and some people for whom I have a lot of respect disagree with me. They think I should be more excited. They say that this will ultimately prove safer, especially in the hands of low-volume ablation operators. My reasons for being underwhelmed. Okay, PFA is clearly not more effective, though this is a first-generation device and newer generation devices could be better. I also worry a lot about brain lesions. When you do PFA, there are intense bubbles formed in the left atrium. A brain MRI substudy of ADVENT was done, and it showed 0 asymptomatic cerebral lesions in the thermal group versus 3 in the PFA group. Now, that's too small numbers to make anything of, but we should have more study of post-PFA brain scans. PFA is faster, but I would argue, how much faster do you need to be than an hour? Another underwhelming feature of PFA is that if you have to do additional lesions, like say, for instance, atrial flutter, then you have to open a new catheter, and then costs go up. Now, PFA will surely be more costly, but also future iterations may fix that problem where we can put PFA onto a typical catheter. My final reason for being underwhelmed is that this is not really a breakthrough. It's just a new way to destroy atrial tissue. It gets us no closer to finding the causes and pathophysiology of atrial fibrillation. All right, next topic, the Budapest CRT trial. This last 2 topics will deal with the necessary collaboration between electrophysiologists and heart failure physicians. I really like the Budapest trial because it addressed a decision that most of us assume is the correct one. But the history of medicine is full up with examples where this reasoning has been disastrous. So I say good on the investigators for studying this question. Budapest studied 2 options for the common scenario wherein patients have cardiomyopathy and high amounts of RV pacing. Let me give you some brief background. If you have severe bradycardia, heart block, or sinus pauses, then RV pacing is better than no pacing, right? But RV pacing causes a dysynchronous RV-LV contraction. That's because RV pacing causes the RV to contract first, then conduction goes muscle to muscle, and then the LV contracts after the RV. This dyssynchrony can lead to LV dysfunction or pacing-induced cardiomyopathy, which occurs in 10, 20, maybe 30% of cases where there's a lot of RV pacing. Pacing-induced LV dysfunction is quite similar to left bundle branch block-induced left ventricular dysfunction. Pacing-induced cardiomyopathy can be corrected by adding a coronary sinus LV lead, because now you can biventricularly pace and activate the RV and LV simultaneously. That narrows the QRS and improves LV function. And we know from seminal trials in patients with heart failure with reduced ejection fraction that de novo or new implantation of devices capable of BiV pacing, we now call them cardiac resynchronization devices or CRT. We know that those devices outperform standard ICDs, but we did not know if, quote, upgrading devices to a CRT would be equally effective. It was not a sure thing, even though we do it all the time, because an upgrade procedure is more complicated. Consider a person who has a dual chamber pacemaker and heart failure with reduced ejection fraction, and what this upgrade procedure actually entails. So if you have someone like this, you have to add a new RV defibrillator lead, because pacing leads cannot be used to defibrillate. You have to add a new LVCS lead and possibly extract the existing RV lead. That's a much bigger deal than an initial implant. Budapest randomized these patients who had high pacing amounts, approximately 85% in the trial, to either upgrade to a CRT-D or a standard ICD. It was kind of similar to mated CRT in that the active arm got a CRT-D, the control arm got an ICD. The primary outcome was a composite of death, heart failure hospitalizations, or less than a 15% reduction of LV and systolic volume. So you mixed clinical parameters and echo parameters, and that was similar to the BLOCK-HF study. And of course, the results were markedly positive for the CRT-D arm. After a year of follow-up, a primary outcome occurred in 32% of patients in the CRT-D arm versus 79% in the ICD arm. The odds ratio was 0.11 or a 91% decrease. Now, if you take out the echo parameter and just look at the key secondary outcome of all-cause mortality and hospitalization for heart failure, this occurred in 10% of the CRT-D arm versus 32% in the ICD arm. That hazard ratio was 0.27, and again, hugely positive. Overall death occurred in 5.6 versus 11% of the CRT versus ICD arms. Interesting also was that the rate of serious ventricular arrhythmias was much lower in the CRT-D arm, 0.5% versus 14.5% for the ICD. Complication rates were similar, actually, in both arms. So my comments. Okay, in this case, common wisdom, that is, upgrade these devices, plausibility was correct. Now, some will look at an 80% reduction in the primary endpoint and think that's too big. Now, they would be right to worry about large effect sizes because often they don't reproduce. For instance, this is a teaser for the next trial that I'll discuss. But I think in this case, it fits the clinical scenario. Why? Because I liken CRT to the Lazarus procedure. When you choose patients well, which is important and relevant to Budapest because they took 7 years to find these perfect patients, CRT can often massively and rapidly improve heart function. I've had people look and feel better in the recovery room after establishing BiV pacing. This is because pacing-induced cardiomyopathy is one of those times you can reverse the LV dysfunction, and if that happens, outcomes will improve. Now, one weakness of the Budapest CRT study, one that I would love to see studied again, is the author's choice to use only CRT-D devices. I think you could accomplish the same thing with the CRT-P or CRT pacemaker. Upgrading only to a pacemaker would simplify the upgrade procedure, as you would only need to insert one LV lead. Now, my evidence for this argument is witness the fact that only one patient in the CRT group had a serious ventricular arrhythmia. Ongoing trials, I think, are happening now looking at CRT-P and CRT-D, and I'm putting my money down on non-inferiority of the two devices. Because think about it, if CRT corrects the LV dysfunction, there is no longer heart failure. And if there is no longer heart failure, there is no longer a benefit for an ICD. I say great job to the Budapest CRT team, and I also wrote a column about that study. Okay, final topic today is one of the most difficult ones, and that's the CASTLE-HTX study. AFib and heart failure often occur together. Sometimes AFib is the cause of the deterioration. There is this select group of patients who have HFrEF, heart failure with reduced ejection fraction, then they have AFib, and boom, things get bad fast. The first CASTLE-AF trial, published a number of years ago, found that in patients with AF and HFrEF and ICDs, AF ablation reduced the composite endpoint of death and heart failure hospitalizations compared with medical therapy alone. The CASTLE-HTX study screened about 900 patients to randomize 200 patients with heart failure with reduced ejection fraction who had AFib and who were referred to their center in Bad Oeynhausen, Germany, to either AFib ablation or medical therapy. These patients were 62 to 65 years old, mostly male, had ejection fractions 26 to 29%, NT-proBNP levels were high at over 3,800, and 6-minute walk tests were low at around 300 meters. I described their features because this comes up in the interpretation. The results of CASTLE-HTX were very positive. The trial had to be prematurely stopped after 18 months. Of the 97 patients randomly assigned to ablation, 16 did not undergo the procedure. However, of the 97 patients in the medical therapy arm, 16 crossed over to receive ablation. After a follow-up of 18 months, primary endpoint occurred in 8% in the ablation arm versus 30% in the medical therapy arm. That hazard ratio was 0.24, or a 76% reduction in the primary endpoint. There were no primary endpoints events, however, in any of the 16 patients in the ablation group that did not undergo ablation. That's curious. Death from any cause occurred in 6% of the ablation group versus 20% of the medical therapy arm. That's a hazard ratio of 0.29. LV function, AF burden, and less use of amiodarone were all better in the ablation arm. So a markedly positive trial. Now, my comments. These results really made a stir at the meeting. On the one hand, ablation proponents rejoiced, right? See, we can help a lot in the treatment of patients with heart failure and AFib. And since I have seen such patients, done AFib ablation on them and watched them do great with less AFib, better ejection fraction, I can understand that if you select these patients well enough, AFib ablation can be a great procedure. But critical appraisal people found a lot not to like. Many criticized me for being too soft in my column, which I hope you read. Here are the criticisms. It's a single-center study and was unblinded. There is a risk of performance bias because it's ablation proponents doing the study. Doctors Sanjay Kaul and Milton Packer both pointed to the huge effect size and the small number of events. Then there is the matter of early separation of the Kaplan-Meier curves, and I mean super early. The authors explain this by saying that these patients were super sick and some were prioritized for AF ablation. But that isn't a totally easy explanation because their EFs weren't that much different from the first CASTLE study, and in the first CASTLE study, the Kaplan-Meier curves don't separate for 3 years. Also problematic is that the average duration of AFib in this study was years, so it's hard to posit acute declines due to new atrial fibrillation. Another problem that I discovered, and is not in my column, but I discovered looking at the trial more closely, is that many of the major baseline characteristics favored the ablation arm. Patients were younger, had better EFs, and lower NT-proBNPs in the ablation arm, for instance. Some of my colleagues called for a large-scale, multi-center trial. Another friend said, hey, why didn't the AMICA trial of AF ablation versus meds in patients with persistent AFib and heart failure show positive results? And I wonder about that too. The best conclusion I can come up with for now is that it is patient selection. If you take patients who have been failing meds and randomize them to atrial fibrillation ablation versus more of the failing meds, then I think ablation will win. And so the best take-home or things that I can do next week is that at a minimum, I think this data supports the early involvement of electrophysiologists in patients with heart failure and AF. We may be able to help in these selected patients. As always, let me know what you think. There's a lot for first podcast from ESC. I'll have more next week. And remember, if you like this podcast, please take the time to give us a rating. Write us a 1 or 2 sentence reviews. These things go a long way to helping others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.